Okay, another case study. This one's relatively simple, but it does highlight a couple things that I see in terms of habits of what patients do. They wait a little bit long. They don't go for regular treatment. They build up some periodontal disease. They have a couple missing teeth. Teeth start moving, and then they can't really chew. And when they can't really chew, that's when they come to the dentist. So, of course, dentists always want to see that people care about their teeth, that they're going to do something, that they're going to be proactive. So this case is a single implant placement. We're looking at what I call the primary chewing area or the primary occlusion area, and we're replacing the lower right side. But let's look at the upper left side because that's where things started. When we look at the upper left side on this case, right here, we're looking at an edentulous site here. And that means that this patient had some years ago lost a tooth there. And what happens to that? Well, teeth do move, and over time they've drifted. And you can see how it kind of opened up the gap. Don't look at this part. This is just a distortion in the CT scan, the way it was spread out, because we're really looking at the bottom here. But this just illustrates the gappage that has occurred where this tooth is now angling in and these teeth are spreading out. So the patient ended up chewing more on this side. And a little clue here of grinding and things has come when you look at the edge of the teeth. All of these teeth are very flat. So if you look at the edge of teeth and they're very flat, I know this patient's a grinder going side to side, and also maybe front to back in this case. But when I see those back teeth really ground down here, they're very flat. Here's a little bit of a tip, but that's because the teeth are a little bit sunken. There's nothing opposing here. That tells me that this went first, this came second. Now, and it was confirmed with the patient as well. But here is the periodontal problem too. Not only is it negligent on replacing teeth, but because there's a periodontal problem, you can see the calculus showing up right here. A big chunk of calculus right there. There's chunks of calculus all through the teeth, all through here as well. So what happens is that this patient is getting a lot of vertical bone loss around the teeth that have the calculus. So she's starting to lose bone here. She's losing bone here. There's a horizontal bone loss, and then you get down to a molar area here, and you see a lot of vertical isolated bone loss here. And that's when the patient herself starts to sense like something's really wrong, because now even more posterior teeth or back teeth are not feeling right. So that pushes a patient to come in the door and go, I need to do something. Once again, it's a financial situation. Once again, they're always worried about spending money along the way. It ends up costing them typically more money down the road. And I think it might be a human habit that we want to just pay one package price for something than like pay half the amount, but in little amounts. Like we would rather make one payment to fix something or buy something than to make 10 or 15 payments but save half the money. Like for some reason, I think our psychology says, let's just make one payment and it's done. And it's like a shot in the arm. Boom, we get it over with. I don't know. I think that's how this goes over time that I've seen patients when money always prevents them from seeking care along the way and preventing periodontal issues and tooth loss issues like in this case. Now, she's actually not interested in restoring this up here, but the warning shot for her is that she will be losing that tooth very soon. And this one is the one that brought her into the office. So this one is an easy extraction. There's really nothing to extract because it's biology is actually doing it for us. And so let's look at this as an implant case. So when we look across the bone, the only concern I have here, the nerve runs very low, which is great But if you can look at that bone here, very hard here, but very soft here. So this is not quite a red, but it's definitely an orange. It's very close to kind of being red. We still have some bone mineral there to actually compress. So when you're placing implants in this site, you always come up very short on your drills. And in fact, what I do, this is an implant that is I think in this case I have an 11.5 millimeter implant, so I will only open up the cortical nature of the bone here, but really just use a very short drill, like a 7 millimeter drill that gets me to a 4.5 millimeter. If this is a 5 millimeter diameter implant, I will only open it up to 4.3, 4.5 at most, but I will only go a certain segment in. I will only take a 2.2 millimeter drill, maybe no more than the 3.5, to take it all the way to full length, just to give the implant a little more guidance. And I want universal compression of the bone outward as the implant goes in. So I don't want to carve out any bone here. And I've even talked to an oral surgeon. He was saying what you could possibly even do is open up that and mix some of that bone that you just drilled out with a graft material and then condense it back into the site. I'm not a big fan of taking stuff in and out because the oral mucosa has a lot of bacteria, and I don't like inoculating bacteria into the mouth like that. So if you're very careful, maybe go for that. But otherwise, I'm not a big risk taker on that front. You could possibly even lace it with clindamycin, see if that helps it not get infected. But I think there's a risk of infection in the bone if you actually do something in that nature. So I don't do that. I like a compressive technique. There are tools for dentists out there watching to actually use to compress it, so you go in with a small millimeter drill, and this is a perfect example of why you would want to use those compression drills. I can't remember right now, but there's a few really good sets. Take a look at our marketplace for these drills that do this kind of compression. Most of them used are up in the upper molar or in the upper jaw area to compress the bone. Here's a very good situation to do that with. So this is a simple one-tooth implant. We would be able to at least restore her back to her primary chewing area, which would be from here to here. And then we need to then hopefully get her back to help this particular chewing area here. So we want to start working on this. This is a little bit different because we have sinus right there, but she has a lot of bone going through the particular area here, up here. But once again, it's very soft bone. So once again, the same thing, a very high compressive technique. But this is a really nice case for a bone compression technique on implant placement.